as pituitary microadenoma is concerned, we no longer believe in CT. We go for MR. If you suspect any microadenoma, go switch over to MR directly. Career of pathologists. Child abuse still in our country, it is on the rise. It is on the rise. Not often recognized, especially nobody. Because, okay, the baby is having a trauma, multiple trauma, or Gilead, that's all. But we don't take care of that. What is exactly the thing, what happened? We are not also aware of the child abuse. Okay? And see that there is special protocol to find, especially the mesotemporal temporal sclerosis, which is one of the important cause of seizure. That can be picked up only with MRI. Okay? So axial T2, weighted image of brain. As far as spine is concerned, now any lesion in the spinal column, unless the patient is having some content, we say there is metallic partial fixed. That is, MR is possible, but that will cause more article. Otherwise, I do CT myogram. But as far as spinal cartilage is concerned, you could directly go for MR for any sort of radiculopathy, for any tumor or trauma, cervicomyelia, metastasis, any vascular malformation, spinal cord edema, or any spinal cord involvement in multiple sclerosis. Again, quadripolar syndrome, tethered cord, arachnoiditis, narrowed. That is one of the important indications of MRI is that the patient having sarcoiditis or any sort of pain or any inflammation or very early and subtle changes in case of say there is some infiltration or early metastasis, CT negative, plain film negative, MR will change, pick up the altered signal, or especially in sarcoiditis or juvenile rheumatoid arthritis. I don't know how many of you are dealing with juvenile rheumatoid arthritis. The first investigation is MRI. Because the marrow edema for bone, there is three things, B, B, C. CT is better for blood, acute bleed, put the patient, you are suspecting MRI, put the patient in CT. You are suspecting any bone injury, put the patient in CT. You can delineate more better. If you are suspecting calcium, you are looking for calciumism, put the patient in CT. B, B, C. Okay? But for any bone, for bone inflammation, bone marrow edema, MR is investigated. That can be picked up much more earlier, before the patient, in fact, there is any changes in any other modality, patient is symptomatic, complaining of pain, put the patient in. Or bone contusion. There is no much change, but there is marrow edema. That can be picked up in, especially in juvenile rheumatoid arthritis. GRA is very important. So in fact, in the spine, you can get the entire detail of the spine in this fashion. As far as musculoskeletal things are concerned, in knee joint, in fact now arthroscopy has lost its glory. Routine diagnostic arthroscopy has lost its glory for MRI. With MRI can pick up any lesion inside the joint. Avascular necrosis, earliest changes, what happens in avascular necrosis, that can be picked up in MRI. Similarly, other soft tissue, bone tumors, osteomyelitis, before any obvious changes in X-ray or the patient is just symptomatic, this can be picked up. Say shoulder impingement syndrome or supraspinal tendonitis, that can be detected. As far as abdomen and pelvis, in fact, we prefer more, in fact, still we are looking for CT, but as far as hepatobiliary system, MRCP is the investigative charge. In fact, it delineates the entire topographical or geographical pattern. I'll show you one or two such pictures. MRCP is the imaging that you do not need any contrast or any endoscope, and it can be done within seconds to show you the entire detail right from the biliary tract, common bile, confluence of the common hepatic duct, common bile duct, and pancreatic duct. MRCP usually should show if there is gallbladder, cystic duct, the integumentary channels, common duct, and common hepatic ducts, common bile duct, and pancreatic duct, and part of the shield. This is a complete study of MRCP. Okay. Although fetal imaging is very diagnostic, but it is not totally done, because then you have to register the machine under PC and PNDT Act.